The Tom Segura dunk injury. How will they fix that? Hey interns, I'm Dr. Chris Raynor and I am not your everyday ortho.
Ladies and gentlemen, can I please have your attention?
Today for Orthopedic Rounds, we are talking about the Tom Segura dunk injury that recently occurred while filming a YouTube video with fellow comedian Bert Kreischer and YouTuber Tristan Jazz.
Bro, what are you talking about, man?
In this video, I'm going to briefly describe the injuries that occurred and then talk about how we as surgeons would typically repair those injuries. First, let's talk about the injury. While attempting a dunk on a lowered rim, Segura suffered a number of serious injuries, several of which required urgent surgical repair. For those of you who are squeamish, now is the time to look away. While driving to the rim, he first suffered an injury to his left knee before falling to the ground and subsequently injuring his left arm and wrist. In the video, you can see and hear the moment when he ruptured his patellar tendon. As this occurred mid-stride and while he was in the air, he became unbalanced and fell to the ground. Unfortunately, as his center of gravity was behind his center of rotation, he fell backward onto his left arm, which was trapped underneath his body. With his left wrist pinned by his hip, his body forced his left arm into internal rotation at the level of the upper arm, causing a fracture there. Tom shared footage from the hospital where he states that he injured his left humerus and his left patellar tendon. The images that he posted showed that he had suffered a transverse diaphyseal or mid-shaft humerus fracture. He did not share any additional information about the specific type of patellar tendon rupture that he had suffered, so it is unclear exactly where the patellar tendon rupture occurred, at the level of the patella, the level of the tibial tubercle, or in the mid-substance. Now that we know what injuries he suffered, let's discuss exactly how we are going to fix those injuries. Let's talk about the humerus first. Generally, for the humerus, we can consider both non-surgical and surgical options for treatment. Usually, internal fixation, where the fracture is stabilized with a surgical implant, is reserved for fractures with an unacceptable reduction or patients with multiple trauma. However, there are a number of indications that help us to make the decision of whether or not to treat a fracture operatively. For the humerus, there are 7 main reasons why we might treat a fracture operatively. Number 1, we are unable to obtain a suitable fracture position after closed reduction. We can't manipulate the bone to look remotely like it is in the right place. 2, new onset radial nerve palsy. The hand and wrist were working before we moved the arm back into position, and then they stopped working after the arm was put back into position. Sidebar. In the video, Segura's arm is initially facing backward while he is laying on the court, and then someone repositions it in its normal alignment. Generally, this is not a problem for fractures, but with this fracture in particular, radial nerve injuries are associated with up to 22% of the cases. End sidebar. 3, multi-trauma patients. Patients who have suffered multiple injuries at the same time. This usually includes motor vehicle accidents and other high-energy injuries. 4, open humeral fractures. The bone is sticking out through the skin. This is not a good thing. 5, segmental humeral fractures. Your humerus shaft is broken into several different segments along its length. This is also a bad thing, and you don't want it for Christmas. 6, a floating elbow. Your arm is broken above and below the elbow, leaving the elbow attached to, you guessed it, nothing. Usually, here your arm looks like spaghetti, and this is not in the least a desirable look. And 7, pathologic fractures. Fractures that occur in the presence of cancer and are usually caused by metastatic lesions that have originated in some place other than the humerus. Here, Segura fits 1, if not 2, of these criteria. At the very least, he has suffered polytrauma, having injured his arm and his patellar tendon at the same time. However, there is also the possibility that he has suffered an injury to his radial nerve as well. I will talk about the clues to that later. For humeral fixation, the options for surgical implants include intramedullary nails, or rods that are placed down the center of the shaft of the bone and secured at either end, or surgical plates that are placed on the outside of the bone and attached with screws to the bone after the bone has been reduced back into position. Most often, plates are used for fixation. Nails are reserved primarily for pathologic fractures. In Segura's case, his surgeon used surgical plates to secure the fracture. The surgical approach is the path that the surgeon will take to access the fractured bone. It is usually a path that is determined by anatomy and is designed to avoid important nerves and blood vessels and to minimize trauma to muscles around the fracture. There are generally three approaches to the humeral shaft: anterior, posterior, and medial, of which the anterior and posterior are more common. It is generally dealer's choice for which approach is used, with surgeons using the approach that they learned during their training or the approach with which they are most familiar. The posterior approach would have the added benefit of allowing the surgeon to directly visualize the radial nerve that crosses the back of the arm in the surgical field during the surgery. The surgeon would be able to inspect the nerve for damage that might have occurred during the injury or during the reduction attempt. Normally, one plate would be sufficient with 3 to 4 points of fixation, or 6 to 8 cortices of bone, on either side of the fracture to provide sufficient compression across the fracture site. In Segura's case, an additional small plate was required to buttress or secure a small fragment not captured by the main plate. Once stabilized, we can expect that the fracture will heal over a period of 6 to 8 weeks. Normally, the patient would refrain from vigorous activity during this period of time in order to minimize stress on the surgical implants and to expedite healing. This usually means that the patient will engage in relative rest, where they keep activity with the involved arm pretty light. If you want to learn more about what happens when you don't allow the bone time to heal before strenuous activity, check out my video on the complications that MotoGP racer Marc Marquez suffered after his humerus fracture. He is already on surgery number 3, and 6 months after his injury, his humerus still hasn't healed. Now remember when I said that there were clues that Segura had suffered an injury to his radial nerve? All of the imagery shared after his injury shows that Segura is now wearing a splint that supports his left hand and wrist. This is often required after a patient has suffered a nerve injury where they have temporarily lost motor function in the muscles innervated by that nerve. Although the radial nerve is very closely associated with the back of the humerus at the level of the radial groove in the upper arm, it is involved with extension of the fingers and the wrist far down below. When motor function of the radial nerve is lost, the muscles that perform these functions in the wrist and fingers do not respond to nerve impulses. The wrist and fingers tend to flex as a result of the unopposed activity from the flexor muscles in what is known as a radial nerve palsy. The splint that Segura is wearing suggests that he has suffered a radial nerve palsy and that support is required to prevent the development of flexion contractures of his wrist and fingers. Fortunately, radial nerve injuries with humerus fractures are typically transient in nature and usually resolve without additional treatment. However, resolution may take up to 1 year from the time of injury. We will have to see how long it takes for this injury to resolve for Segura. Now that we have the humerus covered, let's move on to talk about how we are going to fix the patellar tendon. Once fixation of the humerus fracture was completed, the surgical team would proceed to repair of the patellar tendon with the patella in a reduced position. The technique used for repair of the patellar tendon will vary depending on the level where the tendon is ruptured. If the tendon is avulsed or pulled off either the tibia or the distal patella itself, then the tendon will be reattached with suture anchors inserted into the bone. However, if the tendon is torn mid-substance away from either bone, then the repair will also require suture repair that bridges the tendon rupture in addition to the suture anchors themselves at either end. Depending on the security of the repair, it may also be supplemented with a temporary cerclage wire that is placed around the patella and through the tibia as an additional internal stabilizer while the soft tissues are healing to the bone at the site of the repair. Segura's knee will require immobilization after surgery for a period of approximately 6 to 8 weeks. In his posts after the surgery, we can see his knee immobilized with a knee immobilizer splint. Within a week or two, this splint will likely be changed to a lockable telescopic knee range of motion brace that is more comfortable than the knee immobilizer, but which offers a similar level of protection as the knee immobilizer does. After Segura's patellar tendon has healed, the period of intense physical therapy will begin. Segura will be incredibly stiff after his extended period of immobilization. We can expect him to regain a range of motion in his knee over a 6 to 8 week period of time. Once back to normal, he will begin strength training to restore strength lost after his injury. it will likely be several months before this too is restored. Overall, if all goes according to plan and there are no unforeseen complications, we can expect that Segura's leg recovery will take approximately 6 months, considerably longer than that expected for his humerus. However, if the suspected radial nerve injury is slow to heal, the recovery of his upper extremity injury may be protracted as well. For more in-depth information on patellar tendon injuries, check out my video on Ridge Holland's NXT wrestling injury. I am always looking for injuries to discuss, so if you have a suggestion, then hit me up on my socials. For all of you who have subscribed, thanks for the support and being a part of the Intern Army. If you appreciate this video, tag someone who is interested in medical topics. Thanks for watching, and I will see you for rounds next week. As always, that's been a word from Dr. Chris, not your everyday ortho.
Just a flesh wound.